Again, yes, a mom can get the rubella vaccine and still breastfeed. Okay, anybody else have any questions before we get started? Okie dokie, well, I've hit the record button and I will share my screen. Oh, shoot, I thought I was all ready to go. I got to bring up the other, I went to the next slide and that's not what I want to do. Let me stop the recording, I'm sorry. Record button.
Okay. Good morning, Miss Chandler.
Good morning. So I'm going to stop it and then I got to go out. I'm sorry, guys. All ready to go. Minimize you guys and go find my slide that I need, my PowerPoints. This is part 3. Okay, part 2. Okay. Righty. So I will hit the record button. Share my screen. Okay. All right, so we're going to begin with cord care, or I'm sorry, CERT care. Okay. Circumcision care. So this is in the PowerPoints too. We just have a few more slides to go through. So circumcisions will either be done with a Plastibell or a Gomco clamp. With the Plastibell, they leave a little plastic ring after the circumcision, and then that ring will just fall off. What's great about that is you don't have to put Vaseline, it's pretty much, self-sufficient. Heals really nicely. But I see more often the Gomco clamp where they remove the foreskin or the prepuce of the glands of the penis. And if that is done, then what they do is once they remove that foreskin, they wrap a Vaseline gauze around that site and just leave that until it falls off. Usually within the first few hours, it will fall off. But once it falls off, as long as there's no bleeding, a mom can just put additional Vaseline around that area with every diaper change. For cleaning with the Gomco type circumcision, she'll just want to squeeze soapy water over that area and then rinse, squeezing, plain water over it, and then just pat dry. And, leave the diaper a little bit looser for the first 24 hours or so because it's going to be a little tender. Before they do the circumcisions, they do numb the area with lidocaine or a topical cream. Also, they found that sugar water, sugar substance given to the baby has an opioid effect for pain control. So they give them a little bit of, they dip their little pacifier, or they give them just a few drops of the sugar solution before the circumcision. And that is a new, fairly new practice that they've done, and they find that it helps with pain control. With the Plastibell, it usually falls off in about 8 days. And the Vaseline gauze, like I said, can fall off within a few hours. But, you know, we have mom just leave it there until it does fall off, but it usually doesn't stay that long. So once the circumcision is done, it's important, of course, to check for bleeding. So the nurses will want to check the diaper, check the circumcision area at least every 30 minutes for the next couple hours, next 2 hours. And this is usually done on the day of discharge. So we want to make sure that, you know, mom doesn't leave until we've checked that for a couple hours. And then instruct her that if the area starts to bleed, what they need to do with all bleeding is put pressure, right? So just to, you know, if they can ideally have a sterile gauze and just apply pressure, but if nothing else, you know, a clean washcloth, a dry, clean washcloth, and just hold pressure to that area to stop the bleeding. And then we're going to have them monitor that at home for any signs of infection. Let them know that a little yellow coating over that, over the tip of the penis and the healing area is part of the healing process, and not to worry. But of course, if there's any drainage or, you know, increased bleeding, they would need to call their pediatrician and go in. Breastfeeding for the baby, of course, it is wonderful if we can, you know, if mom is willing to breastfeed, it's very good for the baby, of course. It, you know, the positive things about breastfeeding, one is that it matures the GI tract. It's very friendly to the GI tract. Are not allergic to breast milk, so you never have to worry about a baby being allergic to what their nutrition is. Where some formulas, you know, may be a problem, and the mom might have to change formulas because of that. You know, the breast milk, especially the colostrum, has bunches of antibodies and gives, you know, immunity to the baby for the first few months until the baby can develop their own immunity. You know, so what mom's immune to, baby will be immune to. So it's good stuff. And like I've said previously, that if we can just have moms, you know, feed for the first few days the colostrum, they're doing their baby a great service by giving them the antibodies and the immunity. The downside of that is their milk might come in, but, you know, we talked about all the things that they can do after the fact to decrease that engorgement if that would happen and they don't want to continue. Other findings are that, you know, babies are less likely to die of SIDS. They've also found that it can prevent lymphoma and diabetes type 1, and that it's very helpful in cognitive development. So it has, you know, a lot of wonderful, you know, good things about it that, you know, that help the baby a lot. So, you know, we want to educate moms on that, but again, we don't want to push them into doing anything that they don't want to. So the American Academy of Pediatrics recommend that breastfeeding be exclusive for the first 6 months. So moms should exclusively feed breast milk for the first 6 months and up to 12 months. And if they're formula feeding, they need to feed with iron fortified formula. Or if they're supplementing, also use an iron fortified formula. So the positives for mom are that it decreased their, if with breastfeeding, is that it can decrease her risk for ovarian, uterine, and breast cancer. So it has benefits for mom also. Of course, it promotes the uterine involution, or the uterus going back down into the pelvis. It, as we know, I don't know, as you know, but you may have heard with your moms when you took care of them in OB, or, moms, some of you that have breastfed, that when you breastfeed, that makes the uterus contract. And so that's nature's way of getting that uterus back down into the pelvis to its original spot. It also helps moms lose weight and return to pre-pregnancy, because there are a lot of calories that are, and they can still eat, regular 2,000 calories a day plus the 500 that's needed to manufacture the breast milk. So 2,500 calories a day and still lose weight. So it definitely is helpful in that. It also protects the mom against osteoporosis. Bonding is a definite with breastfeeding, but I always want to say that moms that are bottle feeding also can bond with their babies, also have a closeness with their babies. It's convenient and it does save money. So how does lactation, somebody doesn't have their mic muted, not sure who. Lactation is so prolactin is the hormone that's released after birth from the anterior pituitary gland, and that stimulates the milk production. So it starts to be released after birth, and it's highest during the first 10 days. And it is produced in response to the baby's suckling and the emptying of the breast. So we want moms to feed frequently to get these prolactin receptors activated to establish their breast milk. So it's very important in those first 10 days for mom to feed frequently. So these prolactin receptors can be stimulated, okay? Because if not, it might interfere with their milk production. So that's a good teaching point, that it's important for them to do that, breastfeed every 2 to 3 hours, round the clock, to really get that breast milk supply established. Okay. So it's a supply and demand. So like we talked about with engorgement, usually about third day is when the milk comes in from, first the colostrum and then the true milk comes in. And they can, get engorged, but then that settles down after that initial milk coming in, and it is the supply and demand. So the more the baby eats, the more supply she'll have. So we want to make sure that they, like I said, are feeding that baby every 2 to 3 hours. Oxytocin is what releases it's responsible for the letdown reflex. And that is released by the posterior pituitary gland. So the endogenous inside the mom's body, oxytocin, is responsible for the letdown reflex. And this can even occur if the mom's, once the mom's breast milk is established and she hears a baby cry, she might have that letdown because the body is triggered to let down that milk, or the milk will come to the nipple with the letdown, so it'll be easier accessible for the baby. But it can happen even if she thinks about the baby. So they're going to be wearing nursing pads just in case this happens. Definitely, the endogenous oxytocin in the mom, helps decrease that risk of postpartum hemorrhage. So if a mom is having maybe heavier bleeding than we would like to see, that can be one of the treatments, is to have mom breastfeed to, if that uterus is a little bit boggy and not clamping down well, then we may have mom just, put baby to the breast and breastfeed, because that'll stimulate that endogenous oxytocin to clamp down that uterus. Of course, we need mom's nipples to be erect for the baby to be able to get a good grasp on the areola. Okay, so you kind of see what happens in the picture below here, that when the baby sucks, it triggers a signal to the hypothalamus, and anterior pituitary gland releases prolactin, and milk is produced. Also, with the sucking, triggers to the hypothalamus, again to the posterior pituitary gland to release oxytocin for the letdown. So it's a really cool system that is worked out. Okay. So again, colostrum is the first human milk, and it is thick, creamy, yellowish fluid. And again, it's extremely rich in immunoglobulins, high in protein and minerals, but has less fat. It gradually changes to the mature milk. The mature milk changes during feeding. So once the mature milk is in, and fat does increase at this point. Initially, when the baby's nursing, what the milk is like is compared to skim milk. And then it gets to the whole milk, and then it gets to the hind milk, which is the cream. So you want to make sure that our moms are breastfeeding long enough so baby gets all these different types of milk. So they get, they need the skim, they need the whole, and they need the cream. So they want to nurse for at least 10 to 20 minutes until their breast is empty, and then switch over to the other breast. And then the next time, start with the second breast that they went to first. And that baby nurse as long as, 10 to 20 minutes at least. So we need to encourage moms to do that. So at about two weeks old, the mother should produce about 720 to 900 milliliters of milk per 24 hours. Babies do have growth spurts at 10 days, 3 weeks, 6 weeks, 3 months, and 4 to 6 months. So during those growth spurts, they're of course going to be eating a lot more. So we need to let moms know that, expect to be breastfeeding more because they're having growing spurts during this time. Somebody's mic is muted still. I hear not a lot of distraction, but just a little bit. Different positions moms can breastfeed in are the football, which is, bringing the head up and the legs, underneath your arm, just like you would carry a football for a touchdown. And that can be a very comfortable position, especially for moms with C-sections, abdominal cramping. So it can be a great position. And what we want to encourage our moms to do, of course, is to change positions. So all the milk ducts get drained with breastfeeding. So we want them to, do the football. The cradle, of course, is just, holding the baby like you would if you were cradling them. Lap is more of a side lying. And they've got those breast pillows, boppies, is that what they're called? I think so. That are great to prop that baby up, so mom can do the side lying or lap. Oh, the side lying is with mom laying on her side, which is a great position for nighttime feeds. And so what you can do is have daddy go get the baby, change the baby, and bring to mom. So she can just lie in bed and feed the baby. Of course, we want to make sure to tell mom that, you don't want any, you don't want to have the baby sleeping with you. There's too many covers. There's a risk of SIDS with that. So, and what happens is a hormone's released with breastfeeding that relaxes you, so you could easily doze off. So dad's job also is to make sure once the breastfeeding is done, that the baby gets moved back to the bassinet or the crib. Okay. So latching on is very important with breastfeeding because if there isn't a good latch, then mom is susceptible to having breakdown of her nipple, redness, cracks, blisters. And once those occur, and it makes breastfeeding very uncomfortable, and it takes a long time for those to heal. So we want to prevent that from happening. So a good way to have the baby latch is for the mom to support her breast with a C. So we want moms to hold their hand far enough back from the areola that baby can get a good latch, yet direct baby to the breast. So we don't want to bring the breast to baby. We want to bring baby to the breast. And what they can do with the C position is with their nipple, kind of tickle their lower lip, and that causes their mouth to open wide. And then, place them on the breast over all the areola. And we want to make sure that mom makes sure that she has as much of the areola as she can in the baby's mouth. So as you can see on this picture, that nipple gets pulled way back in the back of the baby's throat. Here's the palate. So they need to have a very deep grasp to be breastfeeding correctly. And that, of course, helps them to empty the breast completely. Okay, let's see, areola and breast tissue. Ducts. Okay, so you can see that grasp there. Okay. All right. Let's see. So, tongue needs to be down. And we know that baby is doing well breastfeeding if we can hear the baby swallowing, that mom is having no pain, and that she can feel the letdown. Now, that might not occur, typically is not going to occur until mom goes home. So we want to instruct her on that because moms are going home so quickly. Usually vaginal births are going home in 24 hours. They like baby to stay 24 hours so they can get all the testing done necessary. And especially if moms have other babies, they want to get home to those other babies and they know what to do. And so they're very confident to go home. But even our first time moms are leaving very quickly. So we want to make sure that, we're doing a lot of teaching definitely with our moms before they walk out the door. But of course, we're always accessible in the nursery and, they can call us, or not in the nursery, but on the floor and call us with any questions. We're there 24/7. So, let them know that we can definitely help them with any questions that they have. If it's in the middle of the night, somebody will help them. So those are signs that we want to look for in the baby when they are in the hospital. And even, with a colostrum, we want to hear them swallow, or we want to see that they're swallowing. Okay. So they don't say, as Ms. Shive said, that you need to feed your baby every 2 to 3 hours like we used to. Every time I go back, every year, things change a little bit. But they do say baby should eat 8 to 12 times in a 24-hour period, which equals every 2 to 3 hours. But, they don't want moms to be so rigid as to, okay, it's 2 hours, I need to breastfeed again. But make sure that they get at least 8 to 12 feedings in a 24-hour period. So, if baby's in a deep sleep, it's okay. We don't want baby to go too long. Some moms, we have to encourage, you really should wake the baby up. It's been 4 hours. Okay. So when it hits 4 hours, it's time to stimulate that baby to wake up and feed, okay, because we don't want too much time to go by, but not as rigid as to say, okay, 2 hours, you need to feed that baby. When the baby is on the breast, of course, we want to, when it's time to remove that baby from the first breast and burp them and then put them on the second breast to nurse, we want to make sure that they're going to break the suction. So we instruct them to put their finger in baby's mouth, stop that sucking, because if not, that's going to cause trauma. If we try to remove the baby without breaking their suction, it could, be traumatic on the nipple and cause nipple soreness just from doing that. So definitely want to tell moms about that. Again, we're going to alternate breasts with each feeding. Start with the first breast and feed until the breast is empty or until the baby stops nursing. And in the beginning, what you can do is use a safety pin as a reminder of which breast you finished on. Okay, so feed on the first breast, burp the baby, come over to the second breast, which they may not feed very long on the second breast or totally drain that second breast. So we want them to start with that breast because, of course, the babies suck and hunger is greater on the first breast. So they can do a little safety pin as a reminder until they can kind of feel the difference, or just to help them remember, okay, which breast do I need to start with? And again, burp the baby after between breasts and then after the feeding. And babies that breastfeed don't necessarily burp that much like our formula fed babies, but they need to attempt it because they do swallow some air. So, they may not burp, but at least try to burp them before you change breasts and at the end of the feeding. Okay. All righty. Formula feeding. So 3 types of different formula is our cow's milk based formulas, our soy based formulas, and our therapeutic formulas. And again, your formula is made very well, and companies are, enriching them with more vitamins, especially D, iron, and LCPUFA for visual development. So they're good. They're good for baby. They're fine for baby. So, that being said, it's okay to formula feed. Soy is used if the baby, we all start them off with the cow's milk based formula. And then if a baby starts having a lot of regurgitation of the formula, fussy, just doesn't seem spitting up a lot after feeding, they may opt to change baby to a soy-based if they feel like it could be a lactose intolerance. And also if the parents are avid vegans, they may want to start with the soy-based formula. Therapeutic formulas are used when there's an allergy or intolerance to milk, cow's milk also, or so if some of the soy-based don't work, they may put them on Nutramigen or Alimentum. I'm not as familiar with that, but they're very expensive. So we want to not switch babies too quickly to the other formulas. So with formula feeding, the best and most economical is the powder because you can mix as you go. But the important thing with the powder is you're adding water, and it needs to be precise. It needs to be the right amount of water, not too much or not too little, or there can be some nutritional issues. So proper mixing is very important with the powder. They also have, liquid that you can dilute with water, but it doesn't keep as well. So the powder, is usually the best bet to go. And of course, there's the made formula. It's more, it's more expensive. It's the most expensive, then the liquid, and then the powder's the most economical. And of course, then you've got to use that up within 24 hours. So again, it might not be the best way to go. Adding cereal, they're not doing that as quickly as they had in the past, but because of the gluten allergies. So, I'm not sure exactly how they're adding cereal these days. It's been a long time since I had a little one, but definitely they don't want to start cereal until they talk to their pediatrician. Because really the intestines in the beginning, for sure, for the first 3 months, cannot handle that thick concentration of cereal. Okay, and there's a lot of iron in cereal, and that can interfere with disease fighting ability of the infant. So definitely want to tell moms, adding cereal, you need to discuss that with your pediatrician. And you see that never prop bottles with all those exclamation marks. This is a time that you need to bond with your baby, cuddle your baby, love on your baby during the feeds. So, you need to hold your baby to feed them, even when they're even when they're bottle feeding, and definitely never put them down in the crib with a bottle. Okay, this can cause tooth decay, ear infections. So yeah, that's a big no-no, to never put them in the crib with bottles or propping them. Okay. And another little point is they should never use honey. Okay. And I'm not sure what age they can get honey these days, but definitely not as a newborn or in the first year, because of the risk of botulism. Okay. Concerns, okay, with feeding. Is the baby sleepy? If our babies are a little bit early, if they're born a little premature, a couple weeks early, they might be more sleepy than our full-term babies. So sometimes we have to wake them up to feed, especially in the first few days. So, what you can do is loosen their clothes. The skin to skin is wonderful. Have the baby, all the clothes taken off except the diaper, put them on mommy's chest, and then, they'll smell the breast milk, and that will help wake them up to feed. But sometimes we have to, change their diaper, get them nice and awake. We don't want them fussy. A fussy baby is very difficult to latch on. So we don't want, and that's a late sign of hunger. So we really don't want the baby to get so frustrated that they're really, very, very fussy. So if they're fussy, we want to try to calm them down before they nurse. So it might be their diaper needs to be changed. So change their diaper, hold them, swaddle them, talk to them softly or sing to them, and try to get them settled down before you try to nurse. So slow weight gain, it can be an issue with our babies, breastfed and bottle fed. So that's another reason why babies are going into the pediatrician after a few days at home. And then they typically, after that, have a 2-week weight check out also, to make sure that they're gaining weight, because there might have to be, if they're breastfeeding, they might have to be supplemented, or something needs to happen there if they're not gaining weight correctly. Storage of breast milk, just to go back to that a little bit, it can be in the refrigerator for up to 8 days. It's got a wonderful bacterial static quality to it, so it really does keep well. And it can be frozen in appropriate containers for 3 to 4 months in the back of a freezer. So that's also good. It needs to be in its own little container box. We always say never, ever, never, ever microwave breast milk or formula. So when it's taken out
They
of the
said never microwave formula.
pardon?
Oh, I'm not on mute. Sorry.
Yes, we're talking about not microwaving formula.
Yeah, I was just telling my coworker. Sorry.
Oh,
So sorry, you guys.
that's all right. Maybe she needs to know that, right? So what you need to do is, and you really, once the baby's home, don't need to warm up formula. So if you're mixing it with powder, it's good to go. But if you feel like you kind of want to warm it up, it makes it more appetizing. That's fine for the baby. But what you want to do is just, have like a cup or a bowl of warm water, and just put the bottle in that just to warm it a little bit, shake it up, and then test it on your wrist. And with the breast milk, you want to do the same thing, put it in warm water, let it, defrost, and shake it up and test it. The problem with microwave is it's going to get too hot. There could be some hot spots, and I know nobody wants to burn their baby's mouth. So, never, ever, never, ever microwave breast milk or formula. Thaw in warm water. So, breast care. We talked a little bit about engorgement, mastitis, and yeast infections. But another thing you can do with engorgement for the ice is use cabbage leaves. So you can peel off cabbage leaves, put them in the freezer, take them out of the freezer, put them in your bra, until they get wilty, and then change them out. So that is another good way for engorgement. Of course, you can use ice packs. With engorgement, if you're breastfeeding, of course, we want you to use warmth before, ice after. Okay. Mastitis, we've already talked about that pretty much. But definitely, it's important to not put soap on your nipples, try to make sure that baby's got a good grasp on the areola, a deep grasp. And if they have some soreness, what they can do is express a little breast milk and put it on their nipples, let their nipples air dry. But again, no soap for that. Okay. Yeast infections, what to look for again is what they'll see is, a thrush in the baby's mouth can indicate that. Medications. So most all medications do go through the breast milk, but we need to tell moms it's usually in small amounts. So the rule of thumb is kind of that you shouldn't take any controlled release medications, long acting forms, because those are difficult for the baby to process. So the best time to take medications are after you breastfeed. Use single symptom medications, of course, talking to your doctor about medications that are safe to take with breastfeeding, and also single use as opposed to multi-symptom uses. And watch for the baby to see if they have any negative reactions to those. Okay, well, that finishes up our second set of PowerPoints. Are there any questions? Let me see if there's any in my chat. Anybody have any questions? You can just yell out if you want.
I have a question, Ms. Chandler.
Yes.
About the different forms of the stool. You were talking about it when it was not recorded, so I went to the book and I wrote something down about each day the stool should be, the baby should make a certain amount of stools.
Yeah.
I want to make sure you talked about that, but I wrote it in my notes. I want to make sure I didn't write the wrong thing. So like day 1, day 2, like each day they should produce an extra number of transitional stools.
Yeah, don't worry about too much the number, I won't ask you that, but yeah, I'd have to even look back on that, but I won't ask you about that.
It's okay. I just were talking about it. I didn't quite catch it. It was like if the mom is breastfeeding, then the baby should make like yellow milk stools.
Right.
Okay.
And they're just they're more of a thinner consistency, and in the beginning they're really frequent, so they can have stools after every feeding. Of course, the colostrum has a laxative effect, which is a good thing. So, frequency in the beginning is more often than later on. And actually, just a little side note, breastfed babies, once they're a little bit older, they can go for several days without having a bowel movement, because the breast milk is so well absorbed. But I won't ask you about that. But the first stool is definitely meconium. Then it's a transitional greenish, blackish combination of meconium and fecal matter. And then it gets to the yellow. And then with formula fed babies, it's a little more pasty consistency, a little thicker, and brighter yellow. Does that make sense?
Mm-hmm. Thank you.
You're very welcome. Any other questions anybody have?
Yeah, Mrs. Chandler, the first stool, is it sterile? It's sterile, right?
Yes, the very first stool is sterile.
Okay.
Yeah. And that's why we give the vitamin K, right? Because the baby does not have the bacteria in their bowel until they're exposed to our wonderful environment out here and all our microorganisms. Right. But it's a good thing. They need that, But yes, the very, very first stool is sterile, and then after that, if it was tested, there would be bacteria.
Okay.
Yeah. Even in a second meconium stool, but that very first one is, yes, definitely sterile. Any other questions? Okay. All righty. Well, let's go to the next set of slides. So that's part 3. And there's one more set of PowerPoints, and I had a lot of interruptions yesterday, things I had to get done. So I will get that up. Let's see how many more slides. I know you guys want to know that. Not that many. So like 17 for tomorrow. And that is all, our problems, I guess you would say, with our newborns. Okay, so we'll see how today goes. Try to get those up. Well, I'll definitely get them up before tomorrow. Okay, all righty. So we will get started on the third set. Let me find this. Here we go. Okay, I don't think I didn't hit share my screen, did I? Do that. Get my mouse to work now. Where's my mouse? Oh, goodness. Where are you? Okay. All right. Let me share my screen. Still recording. I'm paranoid about that. Something's not working. Should be able to see. Oh, I know what I'm forgetting to do. Okay. Here we go. Okay. All righty. So this is our high risk newborns. And this is another little slide, just gives a breakdown of the high risk newborn concerns. Of course, cold stress in our little bitty ones is something that's very, very important to avoid. They have the temperature really low on this. So I just want to disagree with them on that. So your book has 97.5 to 99 should be the maintain the skin temperature, 97.5 97.5 to 99. 96.8 is really low. So I would mark that out and put 97.5 to 99. That is what your book has. But of course, we're continuously monitoring for signs of cold, of a chilly baby, and want to make sure, like I said, 97.8 to 98, excuse me, is my perfect temperature. But if they get chilly, of course, you do want to prevent, you don't want to warm them up too quickly or cool them down too quickly. And as we talked about, being too warm is not a good thing either. Definitely, they should have their hat on in the first few days to prevent heat loss. We're going to be definitely monitoring their blood sugar for signs. We'll talk about the babies that we do. Definitely monitor their blood sugar. And in our normal term newborns, we just watch for signs. But these are our high-risk babies. So all our high-risk babies, typically, I want to say all, I'm pretty sure all. I think I can say all. We're very careful to say all, but all our high-risk babies are monitored. We're checking their blood sugars. And then definitely assessing for their tolerance of oral or tube feedings. We'll talk about that. We're going to be, monitoring for their hydration very closely. They can get dehydrated or overhydrated easily. We'll talk about that. We're going to talk about, as with adults, you're going to always check for gastric residual when they are having tube feedings. And definitely want to check for bowel sounds before you give a tube feeding. Any change in their stool pattern. Some facilities want you to measure the abdominal girth to make sure that they're not retaining too much fluid or formula, or having some bowel issues that could indicate that. So, but, so that's an additional thing that could be done. Of course, we're monitoring their weight gain or loss, so they're being weighed every day. Respiratory function, we want to, put them in, we can't raise their head of their bed too much, but semi-prone, side-lying. Even with our preemies, this is the one exception. We'll put preemies on their tummies. They do really well. They like to be on their tummies, and it actually helps with their breathing. But, of course, they're on a monitor in the NICU, and, we're watching them very carefully for any problems, but they really like their tummies. So that's the exception to that back to sleep rule that we always tell moms. So definitely we're maintaining their respiratory tract patency, making sure, that if they need to be suctioned, we suction them. And, this is funny. Sometimes they kind of forget to breathe because of their immaturity, our preemies. So we have to, they're on cardiac apnea monitors. And so when their heart rate drops, they stop, they have increased apnea. And so we have to go over there and kind of, stimulate them to breathe. So we'll, tickle their feet, kind of wake them up and say, okay, you need to breathe. Of course, we're going to be monitoring their O2 therapy. We'll be talking about the importance of that because of the, side effects of too much oxygen. We'll talk about some of those. And always, always, always assessing for any respiratory distress. So those signs would be a baby grunting, nasal flaring, coarse color change, cyanosis, or increased apnea greater than 20 seconds would be a concern. And of course, our high-risk babies are on monitors, and the monitor settings are set to pick up on that. So that helps. Okay, that's it. Just a little overview of what we're going to talk about. But who are our high-risk infants? They're considered high risk according to their birth weight, their gestational age, or a predominant pathophysiological problem. The first set of babies we're going to talk about, you see these twins that one got a lot more nutrition than the other. Sometimes that happens with our twins. But our first set of high risk newborns are our IUGRs or our SGAs. IUGR stands for intrauterine growth restriction, and SGA is small for gestational age. And these babies, their rate of growth does not meet the expected growth pattern. These babies can be full term, preterm, or post term. Okay. And they fall into the less than 10 percentile for their birth weight. So it can be, there's many factors involved what can cause this to happen. Some examples are, twin pregnancy. You see these two, are twins, and you can see that one is bigger than the other. So the one got more nutrition than the other. So that can cause that. Also, both of them can be small. Maternal factors, if mom has heart disease, hypertension, smoking, or diabetes, it can be due to poor perfusion to the baby. So the baby's not getting adequate nourishment from the placenta because of, those factors in mom's history. Or if mom has used teratogenic drugs, which means that they are harmful to the baby. Could be that the mom's placenta is a previa. Okay, so it's not as getting as much, again, blood supply to the baby because of that. Or could be from a congenital malabnormality. Okay. So these babies are at risk for asphyxia at birth. And this is due to the chronic oxygen deprivation in utero. So these are the babies who, are not getting enough blood supply from the placenta. And they've, really struggled in there to keep going. And they just don't have a lot of reserve to withstand the demands of labor and birth. So when they come out, they are in respiratory distress. Also, they're at risk of aspiration syndrome. And this is also due to the utero hypoxia. This can cause the baby to take a gasp during birth. And this leads to either the aspiration of amniotic fluid, or it can, what can happen if they're stressed from labor, which they don't have a lot of reserve because of the uterine hypoxia, and release their first stool in utero, okay, which causes meconium stained fluids. They may also get, when they take that gasp in labor, aspirate that meconium fluid in their in utero or when they're born. Okay, so these, any baby that any mom that has meconium stained fluid, we do want to suction that baby's nose and mouth out really well, mouth and nose out really well when the head comes out. Okay, not deep suctioning, but just the mouth and nose to make sure we get the meconium fluid out. But if they've already done the gasp before they're delivered, then it's already down in there, and that's when we're going to have some problems. Also, hypothermia is a big issue with these little babies because they don't have that nice fat layer of brown fat, subcutaneous fat, because they have burnt all their brown fat or subcutaneous fat, trying to survive, because of the hypoxia. It increases their metabolism and they start burning that brown fat. They're also at risk for hypoglycemia. So these babies are going to be on frequent blood sugar checks for sure. And again, this is because they have an increased metabolic rate due to the heat loss and decreased amount of glycogen stores when they're born. So they're at risk for that. So, they don't have that fat layer to cushion them. And so they're trying to get their heat up. They're trying to deal with that at delivery. And so with dealing with that for metabolism, increasing their metabolism, they need sugar. So they're burning all their glycogen stores. Or if they were hypoxic in utero, they've also burnt a lot of their glycogen stores up already. So they're definitely at risk for hypoglycemia. Also, polycythemia we do see in our IUGRs and SGA babies. And this is the physiological response to the chronic hypoxia in utero. So what they do is to compensate, they increase their production of red blood cells. So they have a lot of red blood cells because of that, additional red blood cells. So that's why we call that polycythemia, or why that develops. So these babies have some issues, and there is a poorer prognosis in these babies if they're born before 37 weeks. So they're small and they're preemie, okay? And so they have a poor prognosis if they have congenital abnormalities or anomalies. If, they were delivered early because of an intrauterine infection, or that is what's caused them to be small. Or if they have continued growth difficulties or cognitive difficulties. So these babies can have ADD and ADHD issues when they get older. Okay, next we have LGA babies. And LGA babies are large for gestational age. And these babies their weight is above the 90th percentile on the graph and at any week, okay? So we plot them out according to their gestational age on a graph, and they hit the 90th percentile. Why does this happen? Mom's a diabetic, either, she had diabetes mellitus type 1 coming in, or she developed gestational diabetes during pregnancy. Large babies can be a genetic predisposition. Some cultures just have bigger babies, okay? If moms had previous babies, if you talk to moms, typically each baby gets a little bit larger. And so sometimes, if they're on their third baby, that baby's going to be even larger than the first, definitely. So multiparous women, our male babies tend to be bigger. Or if it's a congenital condition. One of the congenital conditions that can cause this is transposition of the great vessels, okay? What are they at risk for? They're at risk for birth trauma, okay? They're large, and it could be that mom's pelvis is not large enough to accommodate this large baby. So it could be due to cephalopelvic disproportion. In other words, the head is too large for the pelvis, or the pelvis is too small for the head, okay? What this can lead to is birth asphyxia, difficult delivery, and baby has respiratory distress at birth. Shoulder dystocia is where the shoulders get stuck. So that can be an issue with these large babies. And if a shoulder dystocia occurs, which means it's very hard to get those shoulders out, they'll have to do suprapubic pressure to try to pop that shoulder down underneath the symphysis pubis. So that can end up with that baby having a fractured clavicle or other fractures. But a fracture is always better than a dead baby, right? So we can fix that. But sometimes that would occur. Also, facial paralysis can happen with the babies from the birth trauma, or cephalhematomas, as I talked about. If it's picked up before, the birth occurs, they would have a C-section. So these moms would be failure to progress, situations that, it's not picked up beforehand, that this baby's not going to fit through the pelvis. And, unfortunately, and we've seen this, we just saw it week before, not last week, but the week before, where a mom labored. My students were there watching her try to push. And it was time for us to go. And it didn't look like it was going to be happening anytime soon. So we found out the next day that she ended up having to have a C-section. And she also ended up with postpartum hemorrhage because she had labored so long and pushed so long. So bless her heart.
Yeah, it was our group.
She had a rough time.
Yeah, that was the group that I was in with Bryn.
Yeah. And then she had a postpartum hemorrhage and got that, what's the name of that again?
It's like a weird name. It's like a balloon in the cervix.
I should have kept my little paper out. Starts with a B.
Bakri balloon.
Bakri. Thank you. Bakri. So yeah, she had to have that. So baby number 2, what do you think is going to happen? She's going to end up being a scheduled C-section. And, a lot of times that's how that happens. That's how that transpires is, they go in and, everyone thinks they're going to be able to deliver vaginally, and, they get to the end and it's just not, that baby's just not coming down through that pelvis. So they end up with a C-section. So these moms would be a repeat C-section with the next baby because they would not want to go through that. Also, if they had a baby, if they were able to deliver that baby, but the baby had asphyxia and shoulder dystocia and a fractured clavicle, they would strongly recommend having a C-section the next time because of the problems that, occurred with that first baby. It's more likely that second baby's going to be bigger. So they would be, set up for a scheduled C-section. But unfortunately, sometimes we don't know that ahead of time, and that's when these things happen. So these large babies are at risk for hypoglycemia. And most often it's with our diabetic moms, which we'll talk about on the next slide, and we'll talk about why. They also have polycythemia, and which causes their blood to be very thick, this hyperviscosity. All righty. So next is our infants of diabetic moms, which are typically our large babies. And it happens typically because of poorly controlled or blood sugar. But even if the mom is gestational diabetic, they tend to, and we'll talk more about this in a minute, they tend to have large babies, no matter how well controlled their blood sugar is during pregnancy. So we call that a macrosomic baby when the baby is LGA. And they tend to have a very ruddy color, which is that red color. And they do have excessive fat tissue. The excessive growth is due to the exposure of the high levels of maternal glucose. And what happens is the fetus responds with increased insulin production to, deal with the mom's high blood sugar, which the baby's exposed to. And this causes, of course, the pancreatic beta cells to be larger, become hyperplasia of the beta cells. But there's something about that insulin, that increased insulin in the fetal metabolism acts as a growth hormone. So because that baby is, manufacturing more insulin to combat the high blood sugar in mom's blood, that causes even more growth. Okay. So that acts like a growth hormone. So that makes our babies bigger. Um, so hypoglycemia occurs also because that baby is used to producing all this insulin at birth. And so they still have all this insulin floating around. And then, so in a matter of hours, that baby's blood sugar is going to start to drop because of that. So we want to be watching those babies closely for signs of hypoglycemia. And those are tremors, cyanosis. So they'll be very tremulous. Now, I know you notice with the startle, they'll tremble a little bit, but these are, constant tremors. Okay. These babies could be cyanotic, having apnea longer than 20 seconds. Their temperature may not be stable. It's either up or down. We just can't get them warmed up. That could be an indication. And remember, as I said, so if you've got a baby whose temperature's on the low side, and we put them skin to skin and come back and, put them in warm blankets over mom with skin to skin, and we check them again and it's still low, the next thing we need to do is check that blood sugar, because they're burning sugar to try to warm themselves up. Their metabolism is speeding up, trying to warm themselves up, and they're burning all their blood sugar. So that would be the next step to do on that. They're not eating well, could be a sign of that. They're just kind of lethargic, decreased tone, just like our adults get, lethargic if their blood sugar is low. And it could, in a severe case, babies could have a seizure, and we definitely don't want that to occur. So we definitely want to check it, be on it before that would happen. So especially in these babies, we're monitoring their glucose very closely. So they've got a whole protocol on when to check it. Typically it's after the feeding, I believe. I haven't updated myself on that, but typically it's after the baby feeds. Could be before the baby feeds, could be after the baby feeds, but just definitely checking that blood sugar frequently. I have to pull that out on our break and look at their protocol, because they've got a very clear protocol on that. So any blood sugar that's less than 40 is considered hypoglycemia. Of course, we want it to be 45 or greater, right, for our full-term babies. So they definitely are treating them, and if it's less than 40. Early feedings, that's what we want to implement definitely on these babies. So these babies especially want to get them, if they're breastfeeding, to the breast, in that first 30 minutes after birth, and feed them every 2 to 3 hours. So they really need to be on early feedings and frequent feedings. These are the babies we're going to definitely wake up to feed. And if we can't stabilize that blood sugar, they may have to go to the nursery and have IV D10, D5 started. Glucose. Okay. They're also at risk for hypocalcemia. So we want to monitor their blood work. And this is also a sign of this is tremors. But the first thing we think of with these babies is their blood sugar. Okay. So if you get a question about that, that's what we're suspicious of first. Okay. The reason why they have low calcium is because our diabetic moms tend to have low magnesium, and this will cause hypoparathyroidism. Okay, so the parathyroid is not shooting out calcium. So that would cause their calcium to be a little bit low. Okay. And it can, actually cause tetany. Low calcium can cause tetany too. So, we're alarmed. We're looking for that. So if you check the blood sugar and it was okay, that might make you question whether the calcium's a little bit low. And of course, you'd call the doctor on that. These babies can also have a problem with hyperbilirubinemia. And this is seen in 48 hours to 72 hours after birth. And the cause is because of the decreased fluid, intracellular fluid, or it could be from birth trauma. Okay. Any of that cephalhematomas tend to make our babies more jaundice. Okay. Because they've got those additional red blood cells to break down, and the breakdown of those red blood cells is bilirubin. So that causes them to have more problems with jaundice. Okay. And they have an immature liver also. So that also causes it. Okay. But they have polycythemia. Okay. So they've got additional red blood cells anyway. And so they've got to break down those additional red blood cells also. And again, that leads to high bilirubin and jaundice. So the babies that we see delivered, if they're ruddy, if they're really red, those are the ones that I'm, going to want to watch and tell mom, you need to really make sure you're keeping an eye on this. And they're being seen, like I said, they're having follow-up visits with their pediatrician, because those are the ones I'm thinking are going to get really jaundiced, because they've got that red ruddiness, means they've got a lot of red blood cells in their system, and they've got to break all those down. So definitely at risk for hyperbilirubinemia. Let's see, respiratory distress due to the birth trauma. If it's a traumatic delivery and there's shoulder dystocia, we're trying to get that baby delivered, the head's out, but we can't get, that the shoulders through. Head trauma, cephalhematomas, could even have a subdural hemorrhage, which is super, super serious, but that can all lead to, respiratory distress at delivery. Another reason to point out about the polycythemia is it's due to the hypoxia in utero. Hyperglycemia and increased insulin results in increased O2 consumption in utero, resulting in hypoxia. So that's what causes the hypoxic situation in these babies. And again, it's because of that hypoxia that they're developing all these extra red blood cells. Respiratory distress syndrome, when the diabetes is not well controlled, insulin antagonizes, in other words, keeps the cortisol induced stimulation of the lecithin, and I'll simplify this in a minute, synthesis, and our lecithin is necessary for lung maturity. Okay. Therefore, our infants of diabetic moms have less mature lungs. Okay. Even if they're full term. Okay. So put it in simpler terms, are increased levels of insulin block the effect of cortisol, okay, which stimulates the lungs to mature. Okay. So they have respiratory distress syndrome because of that. Any questions about our infants of diabetic moms? I think that's really interesting. Babies. Okay. All right. Oh, we need to take a break. Need to tell me, take a break. Okay. So let me stop this, and then we'll pick up with our post-mature babies. Let me go ahead and go to that slide again. Any questions before we get started? Okay. All right. So let me start my recording and share my screen. Oh, before I do that, I did pull out the, let's see if I can show you the glucose monitoring tool protocol, okay, from Novant. So our high-risk babies, birth to 4 hours of age, on our high-risk babies, which are SGA, IUGRs, LGA, infants of diabetic moms, any baby that was in respiratory distress at birth. Okay. Um, so the target glucose from birth to 4 hours is greater than or equal to 40 milligrams actually per deciliter. And they want the initial screen to be 90 minutes to 120 minutes after life, or between 90 and 120 minutes, or 30 minutes after the first feed. So if baby nurses in the delivery room, then they would do it 30 minutes from that point. Okay. So then, they've got protocol. If it's less than 25, you're going to give them glucose gel. I mean, you don't have to remember all this, but excuse me, just to give you an idea. And then place skin to skin and feed, and then repeat the blood glucose in an hour after the gel dose. So it's very clear what you need to do. If it's greater than or equal to 25, then continue to feed every 2 to 3 hours and screen the glucose prior to each feed. Okay. Then it goes on, what to do. From 4 hours to 24 hours, the target is to have that blood sugar glucose greater than 45 milligrams per deciliter. Feed newborn every 2 to 3 hours and check blood glucose before each feed. So I was right. They're doing it sometimes after and sometimes before, just depending on how old the baby is. So it is really nice that you've got clear guidelines from the hospital, or from the physicians, I guess I should say, more so than about what you need to do. Okay. All right. So we will move on. Any questions about that? Okay. So let me share my screen with you and we'll get started on our post-mature babies. Okay. So babies are considered post-mature if, okay, just checking something. If their gestation is beyond 42 weeks, regardless of their weight. And usually babies, we don't let babies go 42 weeks, right? Moms come in to be induced. They don't even let them get close anymore. If a mom, hasn't delivered by 40 weeks, they usually are going in and, setting them up for an induction. So we don't see this very often. Where we would see this if, say, the dates were off, okay? And they can be off 2 weeks either way. So we thought this baby was 40 weeks, but it ended up being 42 weeks, okay? That can happen. So that's, the time where we might see this occur. And what I'm seeing more so is that they're inducing about 39 weeks just to make sure that, we don't get into a problem. But anyway, if this would happen, baby comes out and has all the signs of being post-mature, we would consider them 42 weeks, okay, gestation. All right. Most of them are normal size, but some can actually continue to grow. If that placenta is still functioning well, they can continue to grow. Now, if it's not functioning well, then, babies can be a little bit smaller, but typically what we're seeing is they're, average size when they're delivered. What we do see in these babies are, because of the advanced gestational age and placental aging, with placental aging, it's not working as well, right? It's done its job and starting to not function as well. And some of the other characteristics are due to this baby's been in this amniotic fluid longer than 40 weeks. So when they deliver, these babies can appear very wide-eyed and like, oh my gosh, you finally got me out of there look in their eye. And that can just be from, the fetal hypoxia in utero, that they've just not got good blood supply from the placenta, and they're a little bit stressed. So they come out with these big wide eyes. And typically they are dry, very dry. Their skin is cracked and peeling. They have no vernix. Okay. Remember, we see a little bit in our term babies, just in the creases. Of course, we see more in our preterm babies, are covered with, and we'll talk more about our preterms in just a minute, covered with vernix. But our post-mature babies, post-state babies, they don't have any vernix at all, and they don't have any lanugo. And again, there's more lanugo in our preemies, and may see some in our full term, but there is none in our post terms. Their fingernails tend to be long and actually might be stained with green or yellow, depending on how long they've sat in that meconium. Okay. If they've been distressed, hypoxic in utero because the placenta wasn't, functioning well, they're going to release that first stool, that meconium, and they're going to be sitting in that meconium stained fluid for a while. So if it's thick meconium, they're going to, if it's been in there for a while, they might even have yellow tinted nails. But if it happened during the stress of labor, their reserve, they didn't have the reserve for the stress of labor and delivery and passed meconium during delivery, then they might just have green fingernails. But anyway, their fingernails may be stained and they're going to be long. Lots of hair, and the body will appear long and thin. So these babies are at risk for hypoglycemia because of the nutritional deprivation and the depleted glycogen stores. If their placenta wasn't working well, they're burning their sugar, their glycogen stores, trying to keep going. Okay. So these babies are definitely at risk for hypoglycemia. They're at risk of meconium aspiration, especially if they've passed that meconium before delivery. That's going to be the meconium fluid, right? Because of that hypoxia as the stress of labor begins. Okay. So they might do that gasp before they deliver or at delivery and suck that meconium stained fluid down into their lungs. They also can have polycythemia from the same reasons that are LGA. Well, not exactly. Well, no, just forget that. We'll just talk about post-mature because of the hypoxia. I was thinking of our insulin dependent babies, but that's a different story. It can be hypoxia, but different reason. Okay. So, that placenta is not working as well. So they're in a hypoxic state. So compensation kicks in. They, produce more red blood cells. And that, of course, makes their blood thicker and they have more red blood cells. Of course, that's going to lead to jaundice, right? Also as a risk factor. Sometimes these babies have congenital anomalies, don't really know why. They may even have seizures because of the real hypoxic state that they've been in for a prolonged period of time. So when they're born, they may end up having seizures. Not a good sign. They actually have cold stress again because of burning up their sub-Q fat trying to survive in utero. Okay, so they've had the brown fat, but they've used it all up, because their metabolism is increased, trying to compensate for that hypoxic state that they're in utero, in the uterus. Okay. Okay. All right. Next are our little preemies. Babies are considered preterm if they're born at or before 37 weeks of gestation. Okay. Their organs are immature and they, of course, lack the adequate reserves of the body nutrients also. Why does this happen? Could be economics. They find an economical factor. Low income moms tend to have premature babies more than our middle class and higher social classes. Preeclampsia, okay, can cause babies to be born early, either because they need to be born early or end up being born early. Maternal infections. So moms can just have a urinary tract infection and go into preterm labor. So, that's a reason why we really, and I'm sure probably, hopefully Ms. Walker talked about that, we're screening moms carefully for urinary tract infections every time they come into the doctor's office, because that can throw somebody into preterm labor or other infections. Of course, our twin pregnancies, our multifetal pregnancies, moms with twins or more than twins are at risk of delivering these babies early, definitely. Incompetent cervix is also a reason where the cervix starts to dilate early, and a placental accident, definitely. If the placenta breaks away from the uterus in placenta abruptio, then definitely we're going to deliver that baby because it's an emergency and it might be premature because of that. Okay, and there's ethical issues surrounding the resuscitation of infants that are premature, and depending on how premature. So they include, do we resuscitate? Who should make the decision? The cost of the resuscitation is justified, if it is, and if the benefits of technology outweigh the burdens in relation to the quality of life. So, with our modern technology, it has allowed us to save babies at a younger gestational age, but not without significant morbidity for that baby. So we do, or the doctors have to have that talk with the mom, before the baby's delivered. And it's tough, it's tough. Hopefully there's time for them to think about it. But most parents say, do whatever you need to do, save my baby, but, we have to explain what problems that baby can have, which we'll talk about if they're born too premature. So the cutoff right now is about 23 weeks, where they will, do resuscitation. Less than that, no. Used to be, when I worked in the NICU a long time ago, it was 25 weeks and those babies had problems. But then we got surfactant, and we'll talk more about that. And it's been our miracle medication for preemies. And they really have done wonderful with that medication. But, again, these really, really preemie babies may have some major issues the rest of their life if we resuscitate them. So it's an ethical dilemma for sure. Okay. So with our preemies, we're definitely looking at respiratory function when they're born. We may see them cyanotic, decreased peripheral tissue perfusion, retractions, nasal flaring, and grunting are all signs that the baby's in respiratory depression or distress, Why? Because the lungs are not mature, right? They're not ready to take over the process of gas exchange. until about 37 or 38 weeks. So ideally, you know, anyone who goes into preterm labor, we want them to hold off till 37, 38 weeks because babies are deficient in the surfactant level. And so these lungs, it's like a lubricant. I think of surfactant as a lubricant, and surfactant keeps those lungs from collapsing every time that baby breathes out. Okay. So they keep them from getting stuck together. So it's a lubricant that keeps those alveoli open. Without that, the lungs collapse. And of course, the respiratory, passages are obstructed because of that. With the respiratory distress, also, we may see apnea greater than 20 seconds, right? So we don't want it greater than 20 seconds. We want it less. And they may come out pink, but then may go to cyanosis, where, they're blue from head to toe. Not a good sign. So oxygen will be involved in treating these little ones. They can get oxygen by an oxy hood, which is the top picture there, or nasal cannula. They have little nasal cannulas for our preemies. Want to make sure that oxygen is warmed and humidified, because we don't want the cold oxygen to cause cold stress or dry out their mucous membranes with it not being humidified. They may also be on a ventilator. So surfactant is administered before 34 weeks. There isn't enough surfactant produced to sustain lung compliance. Okay. So sustain life and lung compliance is decreased, and there isn't enough gas exchange without our surfactant. And the lungs become atelectic and require greater pressure. So that's why we see all those signs of respiratory distress, because they're trying to get that air in and then they're trying to get the air out. How this is given is through the ET tube. So the nurse practitioner, whoever is taking over the respiratory part, neonatal nurse practitioners are usually the people in on these preterm deliveries if time allows. And what they'll do is they'll put an ET tube down into the lungs and squirt the surfactant right down in there. And it just works wonderful to help those babies. Some other issues with our babies are cardiovascular function. So these babies are going to be on blood pressure readings, and they're going to have slow capillary refill, greater than 3 seconds. And normally what we see in a normal delivery is all those things that happen, that's a sequence of events with that first breath. So if our babies are premature and they don't have the surfactant to take in that first breath, that can cause the ductus arteriosus to stay open, because normally, our full-term babies take in that first breath and that closes that ductus arteriosus. So preemies are very prone to hypoxia, and that causes that ductus arteriosus to remain open, and we call that a patent ductus arteriosus. So if that ductus arteriosus stays open, there's increased blood volume to the lungs, and that causes pulmonary congestion. Also causes increased respiratory effort, carbon dioxide retention, and bounding femoral plosives is what we're going to see if that occurs. With these babies, our preemies, thermoregulation is very important, okay? Respirations first, thermoregulation after, right? Next. So what causes this to happen? Factors that lead to heat loss are the decrease available glycogen in the liver because of the prematurity, and brown fat, because brown fat, it does not develop until the third trimester. So if these babies are born before the third trimester, they don't have that wonderful brown fat to help them keep warm and to help them produce heat. So, with the lack of glycogen stores and the lack of brown fat, that puts them at risk for thermal regulation or ineffective thermal regulation. Also, their large surface area in relation to body weight. These babies tend to be in the frog position. In other words, they don't have that protective flexion that our full-term babies have, where they flex their arms and they flex their legs to keep their body warm. So with this frog position, they're just kind of laying out there with their arms open and their legs hanging down, and that increases the surface area that is exposed to the environment. And of course, that increases heat loss. Strong flexion is not obtained until like 36 weeks. So if our babies are born before 36 weeks, they're going to have this frog position. Also, they have superficial blood vessels. Their blood vessels are very close to the surface of the skin. And so heat from the core goes out to the subcu tissue. So they lose heat that way. Their skin is thinner and more permeable, which means it allows that liquid to pass through. Okay. So, that can happen with evaporation. If there's a liquid going to the surface, it's going to be evaporating. And so that leads to heat loss through evaporation. And they have that insensible water loss also that, with that leads to decreased heat. Also, the baby has very superficial blood vessels, we talked about, and they have the decreased ability to constrict those blood vessels to conserve body temperature. So our full-term babies can't shiver. Well, our preterm babies have more of a problem with that. So that causes heat loss in our babies. They, aren't moving around a lot, so they have decreased muscle activity, which can warm up babies, poor muscle tone, and, just their immature temperature regulation center in the brain, which our full-term babies have. So our preterms definitely have even less mature regulation center in the brain. So these babies are typically put on the radiant warmer and until they get more stabilized, and then they'll be put in an incubator. But what they'll have is a skin probe put on their abdomen and with a little patch over it, and that will monitor their temperature and regulate it. It's called servo temperature control. And so it reads the baby's body temperature, feeds it to the radiant warmer for the radiant warmer to either heat up or cool down. And we'll put a range of the temperature that we want baby to be. So that regulates the baby's temperature. In our really, really preemie babies, they may even be covered with polyethylene wrap, okay, wrapped in plastic, because they have so much problem keeping their temperature up. Or be placed in a plastic bag from their feet to their shoulders. I know some of you have had the great opportunity to go to the NICU, and I'm sure you saw some of the littler babies at a Northeast with plastic wrap over them. So hypothermia is definitely a concern. These babies have a lot of problems, and they certainly don't need to be having cold stress issues. So we definitely want to be monitoring their temperature very carefully and closely because of the increased stress it can put on the baby to be cold. But of course, too warm also, okay? Too cold, there's increased oxygen consumption and increased metabolism, which leads to hypoglycemia, right? And respiratory distress. But hyperthermia, being too warm, can also be an issue because that increases, babies trying to cool themselves down, increases oxygen consumption. So definitely don't want them. We want that neutral thermal environment, right? Where the metabolic rate and the oxygen consumption are kept at a minimum, right? We don't want to add problems to these babies. The servo control skin probe reads that to the radiant warmer. Okay. All right. Other problems our preemies have are GI function. So the goal with our preemies is to get them growing and developing. The preemies have less than 34 weeks, have a weak or absent suck, swallow, and gag reflex. So they can't bottle feed for that reason. They also have a small stomach and weak muscles. They require gavage feeding or getting IV fluids, TPN, total parenteral nutrition through the IV. If they're less than 20 or 34 weeks, they'll get gavage feedings. There is an increased risk for aspiration in these babies, and sucking requires increased metabolic rate and oxygen consumption. So we don't want them burning all their calories and putting them at stress respiratory wise trying to eat. So in the beginning, they'll be getting these gavage feedings. And we'll talk more about that in just a little bit. They're also, if you look at their renal function, their glomerular filtration rate is decreased. And that's due to the gestational age and also could be due to the insult to the kidneys if they had asphyxiated, they were asphyxiated, can't say that, at delivery or had respiratory distress. The blood will be shunted to the vital organs like the brain and the heart. And so the kidneys can have decreased blood supply during that time of respiratory distress, which can cause that to affect the kidney function. In the preterm babies, the kidneys are unable to excrete metabolites and drugs. Okay, so they're not able to excrete lactic acid and those kinds of things and drugs. So you have to be really careful when you're medicating these babies because they can get toxic very easily. So definitely, we're monitoring that. Maybe if they're on gentamicin, doing blood work to monitor their gentamicin level. They also cannot concentrate their urine, and they have a problem maintaining their fluid balance. And so they can easily go into fluid overload or dehydration. So we monitor their INO very carefully. If they're getting feedings, when they're getting IVs, those are calculated very carefully as to the amount of cc's they would get per day, per kilogram. And the doctors have all that figured out, or the neonatal nurse practitioners. So also we're weighing their diapers and just keeping really close tabs on what they're taking in. So very, very accurate INO on these babies. And of course, their immaturity puts them at risk for infection. their immunity. They don't have as good immunity because a lot of immunity is acquired in that third trimester. And so their immunity is even more immature than our newborns. So definitely, I know the students I took into the nursery were very aware of the hand washing, the strict hand washing. So these nurses that work in the NICU definitely have to do a hand washing of at least 3 minutes. And, of course, practicing good, strict hand hygiene throughout the day also. But they're definitely at risk for infections because of their more immature immunity. Also, because their skin is very thin and fragile, it can easily be excoriated. Okay, there can be breakdown of the skin, and that also places the baby at a greater risk for nosocomial infections, which are infections they're going to acquire from the hospital while in the hospital. And they get a lot of IV starts, and they get blood draws. So, a lot of poking and prodding, and, and their skin is very fragile and susceptible to breakdown. So we got to be very careful with our preemie skin. So when we look at nutritional care, the physician's going to determine, the neonatal nurse practitioner is going to determine with the physician how much that baby is going to eat, when the baby will get formula or breast milk, how that baby will be fed, and how often that baby will be fed. So it's very closely determined, looking at their weight, looking at their gestation, how they're gaining or losing weight, so that it'll be tweaked every day. It'll be looked at. Definitely the presence or the absence of suck and swallow reflex is looked at to initiate bottle feeding. They've got to be able to suck and swallow, right, and gag if they need to. So in our preterm babies, like I said, they're not going to be bottle fed less than 34 weeks. And they look for readiness to eat, sucking. And we'll talk more about that, with I can go ahead and throw it out here, but with the gavage feedings, if they're not in any distress, then, not having breathing problems, they may suck on a little pacifier during the feeding to get them, try to stimulate that suck reflex to get developed. Of course, their physical condition, our very sick babies, it might stress them more to even have a gavage feeding. So, they have to be stable, no respiratory distress. They might be breathing a little fast, but not in respiratory distress for them to get fed. And of course, we're always going to be checking for residuals from the previous feeding. And, some babies are on continuous feeds and some babies are on bolus feeds. They haven't really found that one is better than the other. So if they're on continuous feeds, the nurse is going to check for residual every 4 hours or so, whatever's ordered. Or if the baby's on bolus feedings where we, feed the baby, pour the feeding into the syringe on the tube, we're going to check for residual. And, if there's residual, you're going to have instructions from the doctor, orders from the doctor as what to do with that residual. If it's a certain amount, we'll return it just like we do in our adults, because we want to maintain that electrolyte balance. We don't want to mess that up. But if it's over an amount, then you'll either hold the feeding, return it and hold it. If it's all mucus, the doctor might say, just throw it out. So you're going to have very specific orders on how you need to handle that residual. Malformations might affect how the baby's fed, and renal function. We definitely want to make sure that that's intact. Okay. Okay, so that being said, the baby might not be able to breast or bottle feed due to respiratory distress or sepsis if the baby's very sick. So they might need to have enteral, OG, NG feedings or perennial feedings, IV, total perennial feedings. What they found more so recently in studies that initiating just a small amount of enteral feedings per the OG tube, and we'll talk OG versus NG on the next page, is advocated. That to supplement it even just with a few cc's, along with maybe total perennial nutrition, is very good for the GI tract. And it's designed, doing this is designed to prime the intestinal tract, and having that little bit of formula in the GI tract is great. It stimulates hormonal and enzymatic functions. So they find it to be very helpful that these babies do better if we can start those feedings early, that they do better and they go home faster. So used to be we didn't feed our babies as quickly, but now they're doing it like in the first 24 hours, starting a little bit of feedings as long as the baby's stable. And it's not a lot. It could be 24 milliliters per kilogram per day that these feedings are. So they're just small amounts, but it just stimulates that GI tract in a positive way. Of course, anytime you're going to give a tube feeding, you're going to listen to bowel sounds. You're going to check that residual. You're going to monitor the stools, and you're going to weigh that baby daily, definitely. They consider that they're happy if that baby is gaining weight, is 20 to 30 grams per day. Okay. That's what their goal is, for that baby to gain 20 to 30 grams per day. Okay. Gavage feedings. So oral feeding is best, of course, but sometimes it's not possible for all those reasons that we just talked about. And typically we put an OG tube in, okay? We put it down the mouth instead of down the nose. Pretty much, I would say 90% of the time, that's what we do. Because our babies are nose breathers, okay? So we don't want to interfere with that. So it's put down in the mouth and it's taped to their little face here. So again, we're checking those residuals as I talked about. And sometimes these babies are given part OG feeds and then part bottle. So they'll bottle feed them. But if these babies, get really tired easily, and, there's a lot of work that goes into sucking and swallowing, eating with a nipple. So they may just do that for part of the feeding, and then the rest of the feeding, for calorie wise that they need more, put it down the OG, just to get that baby used to sucking on a bottle. Then, they'll finish it off with the OG. So that might be a reason to do it. Okay. All right. And I talked about that. If they're less than 34 weeks, they're going to have it poor suck and swallows because of that. And if they're too ill, we don't want to stress these babies out more and them go into respiratory distress, which is going to increase the metabolism, burn more sugar, and we're going to cause all kinds of problems. They're just not well enough to start sucking on a bottle. or if they're on the ventilator, and we'll just give them tube feedings. Okay. So this is a picture of putting down, and it's so much easier to put a tube down a preemie or newborn than it is an adult, but you can see how it's taped. So measurement is from the tip of the nose to the earlobe to the midpoint end of the xiphoid and the umbilicus. So between the xiphoid process and the umbilicus. So we go a little bit further down with our babies in our measurement. And of course, we're going to tape that, and we're going to insert it and tape it to their mouth. And of course, you're going to also check for placement before you give a feeding by aspirating, checking for residual, and then just inserting a little bit of air and listening over the tummy to make sure it's in the right spot. And most of the time, sometimes they can just put it in and take it out, but the trauma of that is such that they usually just tape it and leave it in. And they may be propped over on their right side a little bit just to help with the digestion. So you might notice that towel that's rolled behind that baby just long enough for that baby, that feeding to get through the stomach into the digestive, into the bowels. Okay, so TPN is an option for these babies, these little bitty babies, these very sick, ill babies. So they may have this and a little bit of tube feeding just to, get those enzymes and, things going on in the GI tract that we want to happen. But anyway, TPN is a possibility if they're unable to get enough fluids or calories from the enteral feedings, okay? Or they're sick, too sick to tolerate that. Then there's non-nutritive sucking, and that's just having them, as I said, sucking on a pacifier while receiving the perennial nutrition IV or gavage feeding. And it just helps that baby in the transition to nipple feedings earlier because they get to practice sucking. Okay. The environment definitely needs to be manipulated to provide, good development, supportive milieu. Okay. So, these babies are not supposed to be out in the world yet. And so we try to keep the stimuli down with our preemies. So low lighting in the NICU, you probably noticed when you went in, keep the noise level really down to try not startle them. Very quiet environment. And sometimes they'll even, if they're in an incubator, they'll put a blanket over the top or isolate. They'll put, same thing, they'll put it over the top of the isolate to just keep that environment even darker. Okay, so try to set that milieu to be supportive for these babies, eating, sleeping, and growing. That's our goal. When they're stable enough, they'll start swaddling the baby, and the nurses want to start looking for communication cues from the baby, when they're hungry and what's going on with them. Hopefully they can communicate a little bit with us when they get a little more stabilized. Kangaroo care is important with our preemies also, okay? And of course, kangaroo care is skin to skin. Our preemies, we're going to keep the hat on. We're going to keep them warm. They need to be stable enough that they can not be stressed coming out of the isolate, okay? And it definitely increases the bonding with the parents and the infant. And even you see dads doing it here too. So you'd have baby in a diaper on dad's or mom's chest and warm blankets put over them. They found that it helps maintain their temperature. We use that all the time on postpartum with our cold babies. Okay, do skin to skin to try to warm them up. And they found that babies are better oxygenated. They've got the monitor on, they've got the pulse oximeter on, and they find that the oxygen saturation goes up when babies are doing kangaroo care. So it's encouraged and used with our preemies a lot when they're stabilized. So, we talked about the ethical dilemma with our preemies and deciding if ethically it's a good thing for them to be resuscitated. So just briefly going to talk about some complications that it can occur with our preemies. Now, respiratory distress, I'll talk more in detail tomorrow about that. But that is definitely a factor in our preemies. Another problem our babies can have after being taken care of is retinopathy of the prematurity, is what it's called, and it affects the oxygen therapy, can cause vasoconstriction in the delicate vessels in the eye and cause hemorrhages, can cause retinal detachment that can lead to scar tissue, that can lead to visual impairment. And this can lead to actual blindness. So it's something we definitely want to avoid, but it is a possibility with our preemies. So we monitor the oxygen concentration very carefully. We'll have the O2 sat oximeter on babies and really, not give them any more oxygen than they need to hopefully avoid this, but sometimes it still happens. So when the babies are born prematurely, the vessels in the eye have not reached maturity yet. So they're still growing and they're affected by the oxygen. They don't even actually reach maturity until like 42, 43 weeks after conception. But see, our preemies are on oxygen earlier than that. I mean, earlier than 40 weeks, 38 weeks. Definitely our preemies are. So that oxygen affects, unfortunately, those vessels. So this is a complication of oxygen therapy, but of course we have to have our oxygen for our preemies. Another complication that can occur with our preemies is bronchopulmonary dysplasia. And this is caused by the pressure of the ventilator, okay, and oxygen toxicity. So this can cause an infant to have persistent signs of respiratory distress, and those are tachypnea, retractions, nasal flaring, grunting, wheezing, crackles, irritability is what we're going to see in these babies. They just continue to have respiratory issues. They had to be on a ventilator because of their prematurity and their respiratory distress syndrome. And so that can be caused, that the ventilator can cause this to happen. So these babies typically are on oxygen until they go home. And then, they might be on it for another year or more. So they'll have the nasal cannula and go home with it. They require the long-term oxygen therapy, and it also puts them at risk of more respiratory infections in the first few years of life. So they need to be protected from, in flu season, definitely in COVID season. But, they might have to be on oxygen for a year or longer. Then we talked about patent ductus arteriosus. Again, it connects the left pulmonary artery and with the dorsal aorta, and it's supposed to close with oxygenation at birth after that first breath. But again, our preemies frequently have hypoxia at birth, and that causes that ductus to stay open. If an x-ray would be done, they could see when an x-ray would be done, if it was persistent, it would show that the heart is enlarged and there's pulmonary edema because, the increased blood volume in the lungs causes pulmonary congestion again, increased respiratory effort, carbon dioxide retention, and bounding femoral pulses. This can or may be able to be managed with medications such as diuretics and indomethacin, which is anti-inflammatory, but may have to have surgery when if medical management isn't working. They may have to have surgery to have this repaired. Okay, and then lastly is our periventricular or intraventricular hemorrhage. So this can happen when there's hypoxia and the ventricles in the brain have a bleed. This is one of the most common birth brain injuries in the preemie, especially if they're less than 34 weeks, okay? So the baby's brain ventricles are very susceptible to damage during hypoxic events, such as respiratory distress at birth, birth trauma, even, their little heads, or birth asphyxia if they, have hypoxia and need resuscitation at delivery. The blood vessels rupture in the ventricles, and this causes a bleed into the brain, unfortunately, and can, cause cerebral palsy, seizures in these babies. So that is a definite bad thing that can happen to our little preemies. All right, well, that covers our third set of PowerPoints. So that is all I have for today. We will do our last set of PowerPoints tomorrow. I only have 17 slides, so it shouldn't be a long class. But let me see if there's any questions. Let me get this out of the way. Does anyone have any questions for me? No? You're all good? All right, I got the whole recording. Yay. Okay. With the eye issues due to oxygen treatment, does it matter? Well, we have to have oxygen treatment if that's what I think you're asking. How they get it. No, if a baby needs a ventilator, they need a ventilator. And it doesn't matter really whether they're getting it through the oxyhood or nasal cannula. That's a good question. No, it's just one of those side effects. And we just, we've gotten better at monitoring the oxygen concentration. And, we try to keep it as low as possible while treating these babies. But if they need more, we're going to have to give them a higher dose of oxygen. So the pressure issue is with the brain part, with the bronchopulmonary dysplasia is the pressure from the ventilator. The retinal is just the oxygen, okay? The retinopathy of the prematurity is just because of the oxygen. So if a baby doesn't have to have ventilation, they shouldn't have a problem with bronchopulmonary dysplasia. But if they have to have a ventilator, they're at risk for that. Yes. Okay. Did that answer your question? You're welcome. Okay. All righty. All right. All right. Well, if you don't have any questions, I will let you go and I'll put the recording up. And
Thank you, Ms. Chandler.
you're so welcome.
Thank you so much. Have a good day.
You too. Thank you. And I will see you tomorrow at 10. Thanks,
Yes, ma'am.
guys. Bye.